Once again, thanks for having me here for this GLOHRA Academy series. We're going to talk about collective intelligence for inclusive global healthcare, mainly focused on federated learning. So basically, we'll just start with a pretty little introduction about the lab and what we are doing before we go into the federated learning. As Rebecca just mentioned, we do have the slido.com, so we might have a few questions here and there. So it would be great if you could just join us just by typing slido.com, then enter the number that you see here, or just scan the QR code that you see here on the left-hand side. All right. So this is a little bit about my background. I came from Gaza, Palestine originally, studied there electrical engineering, like my master, bachelor degree there. Spent a couple of years in academia, governmental, non-governmental sector. Before I moved to Germany, work on my PhD. So then moved to TU Munich, and this is where I did my PhD in computer science, and then led a group of a couple of PhD students coming from industry, different backgrounds, working mainly on machine learning with medical imaging. In 2018, 2019, I received this Prime Fellowship from DoD to also do this international mobility, where I spent some time at ETH Zurich, Imperial College London, before I came back in 2020 as a group leader with prestigious funding of 1.8 million euros for 5 years. 2 years ago or 3 years ago, I also received, I've been appointed as a W2 professor at the University of Bonn at the Faculty of Medicine, along with my group leader at Helmholtz Munich to work on, developing federated learning algorithms with medical imaging. So indeed, I do have a couple of people in Bonn and Munich. We work along these three research axes of medical imaging with deep learning, federated learning in healthcare, and affordable AI in healthcare. We have also hosted a couple of visitors from Australia, Japan, Spain, along also with a couple of people from Lebanon, Emirates, to indeed strengthen our collaboration with a global south, basically. Our lab is also affiliated with a couple of entities like Ellis and a couple of graduate school, either in Bonn or Munich. We do have also a couple of academic commitments, basically, and we have been organizing a couple of workshops, conferences as well, mainly interested in federated learning. So this is the first time where it was introduced in Singapore, and then we had it also in Vancouver, and in next week, going to be also at MICAI, the DCAF workshop, which is on distributed and collaborative federated learning. However, also interested in a couple of outreach activities, thanks to also to our couple of funding agencies like the Arab German Academy, where we have a couple of projects on the MENA regions, for example, in Palestine, Egypt. Also, we organize a couple of workshops in Tunisia. I have been also in a fact-finding mission in Jordan and Emirates to see how we could strengthen the collaboration between Germany and Arab scholars, tackling mainly also the problem of bias in AI. Apart from that, I've been also organizing a couple of, or co-organizing a couple of hackathon, basically for radiologists in Germany. But also we had a couple of schools. So this is like the winter school where we hosted a Lebanese delegation of 25 professors and graduates. We also had this in the summer, funded by the AGEA and the PNPF, for 65 people coming from like 17 Arab countries and also Germany, where we have them for 5 days, teaching them basically the basics of AI with also a couple of applications, climate change, healthcare, among others. Now we just comes to the beginning of the talk. So the question that I have for you, how many of you have read that book, The Wisdom of Crowds, for James Servitsky? Probably a few digital hands would be sufficient. The reason I'm basically bringing this book here, because James basically made the point, which is the crowds are smarter than individual, no matter how brilliant they are, right? And he brought a couple of real world case scenarios coming from the CIA, etc., where he indeed just proved that. He set a few conditions, though, that we're going to talk about it, how we could just bring this collective intelligence into place. So basically, the outline of the talk, we just go quickly through the current research themes, how we end up to this collective intelligence federated learning, a gentle introduction to federated learning, before we also talk about the paper that we published like 2 years ago in Nature Machine Intelligence. So before we move on, just have a question for you on Slido. It would be great if you could tell me a little bit about your background. So you could just go to the slido.com with this like QR code and just type in your background, let it be computer science, healthcare, medicine, and so on. So just leave it here for a few seconds. So please log in and just let me know what's your background. That would just help me how we move on with the slides and the complexity of also understanding the concepts, etc. All right. So we have a few health data science, the majority global health, public health. That's pretty cool. Few more. Yeah, we have also computer science. That's also great to see here. But the majority are medicine, global health, public health, or we have also nutrition, pretty cool, political science. Interesting. All right. So please like type in your background, will be anyway stored, recorded. So that's really cool to know more about the background of the audience. So let me just move on with the slides here. You must have heard about the role of AI in SDGs, right? Sustainable Development Goals, and how this is gonna change basically the world around us. How gonna this change also the healthcare, right? That comes also with a lot of, controversial discussion, debate. If AI gonna replace us, like, take a lot of jobs and so on, right? However, there's no doubt that it has a lot of benefits that comes with this AI. Also like economic benefits, right? How this is gonna save also a lot of money, probably improve the performance, accuracy, and precision medicine, right? And this is where a lot of also like a lot of business, a lot of investments goes to the AI or AI startups, and this is like where also expected revenues like in the next few years, right? Let me probably ask you these questions. I'm not quite sure how much like we could make it interactive, but just looking at this image and imagine this is like a self-autonomous car. What the car supposed to know about this scene, basically? I mean, you could just unmute yourself probably and just say a few words. I'm not quite sure if this is allowed, but you could just write a few things here as well.
Sorry, could you say the question one more time?
Sure, sure. I mean, what I'm trying to say, just imagine this is a self-autonomous car, which means like there's driverless. The machine or this car supposed to know about the scene that you see here to drive safely, basically.
I would say knowing the hazards, like so all the people for one, and the cars.
That's right. So we need to know about the cars, right? I mean, probably the lanes, right? Which direction, right? The cars, the objects, and somebody mentioned about the risk factors, probably. I don't know if this is quite relevant, but if you talk about, yeah, like pedestrian, right? Who are crossing the street, right? What else? Direction. Yeah, that's right. What else? We need to know the signs, the traffic signs, right? And the traffic lights, the weather conditions. Awesome. So all of this, right? And we may need also to estimate the distance between the car and also the pedestrian, the cars, the nearby cars, right? And maybe we need to know also what they are planning to do. Are they going to go left, right, and so on? So all of this object detection, scene understanding, right? All of this really needed for an AI model or a machine that could just basically drive the car safely, right? So we need to maybe process sounds probably from the driver or probably for the people like they are just picking up the car. listen properly to the surrounding area, we need to see as well, right? So all of the sensing devices need to be processed to be able to, probably just move on with the car safely. There has been a lot of also progress have been made with the AI. You probably have seen it, but this is one of the interesting stuff that you could also try it yourself. Well, they do the translation, but keeping it or preserving the expression. So you could see here, like one of my examples.
We're glad you're here. I'm so happy to see you. Je suis si heureuse que tu sois là. Je suis si heureuse de te voir.
So you can see how this has been translated from English to French, preserving the expression, like how you say it, basically, right? So this is came from Meta, basically, a proper year ago. You could also give it a try here on the link. But there's also another few works like segment anything, where you could, for example, from this petri dish, if you want to, count how many bacteria colonies, you could basically use it to do that as well, right? However, most of these models have been trained on millions of data, right, to make this happen. And that brings us also to the challenge that we do have in medical domain. Basically, there are a couple of papers that were just came out, discussing the challenge that we do have in medicine and healthcare. And probably one of the major challenges that we do have is the data limitation, right? So we don't have much data in the medical domain. And I would also like mention the equity and bias. This is the fairness. This is also another, factor that we probably, in most of our work, just we probably miss, right? So that brings us to our research portfolio and how we shape it basically. In simple words, just imagine that you do have two classes like A and B, or malignant and benign, basically. Imagine those are labeled. So you are physicians or healthcare professionals. You know this imaging data, or this is like whatever records, health records that you get it, and you know this is benign and malignant, right? However, you don't have the time to really annotate every single data points if this is benign and malignant, because you do have also other business to do. So imagine they do have also a few more unlabeled data. Those are the gray points. And what we would love to do basically is just to build a classifier basically, just to say, well, this is basically blue and this is green, right? So we need to draw a decision boundary here for any data points that came in later on, just tell this is like benign or malignant. So this is how machine learning model work. Based on previous data points that you labeled, we teach a model either like for decision boundary for classification, or a regression model to estimate, for example, the age or the density and so on, based on historic data that we collected from our physicians, basically. Now, we have indeed developed a couple of works using this basic concept, from femur fracture detection to, classification of liver diseases, to also helping the physician during the COVID of quantifying the ground glass opacity or other pathologies in chest and thorax CT, basically. However, when we collect more data coming from different hospitals of different institutes, we have this problem, we call it distribution shift or domain shift. Think about it also like probably there are a lot of people coming from like a global health or like a healthcare profession. Think about, for example, naive example, breast density and breast mammography. There is a couple of evidences that we know it that the breast density differs from one ethnic group to another, right? So imagine we do have a data coming from particular ethnic group, and now we want to just do a breast density estimation. Now, if we have data coming from a different distribution, then this basically won't work out, right? So this is like, raise another issue to AI models, and this is where we try to tackle those issues by either like techniques called domain adaptation, because like state-of-the-art models, if you just plug and play on data, for example, here for left atrium segmentation, for cardiac ultrasound, basically won't work out of the box. And we have to really, involve some prior knowledge, some geometric constraint to make it happen. You could also think about it differently, and we could probably go from like image to image translation. So there's like, this is one of the interesting work that we did with our partners from Roche, Well, we try to move this data, which is hematoxylin eozyme stained image, to immunochemistry stained data by only using AI. So trying to basically avoid this complexity or this challenge by going to different lab, which is, well, probably not quite available to do the immunochemistry staining, and we can just do it with this virtual staining. It might sound crazy, it might sound quite challenging, but this is indeed what we have been doing. And we try to match it with indeed the real staining, which is quite close to it, basically. Well, we haven't been only working with medical data, but also there's a series of work that we work on also electronic health records or like some meta information like age, gender, and so on. And this is particularly true for brain imaging, like the Mercian, etc. We have also done it for segmentation, tumor segmentation, like for example, the treatment that we gave to the patient. This is basically for mice patients, and we try to see if basically the treatment has a role in also segmenting or trying to see the progression of the tumor. This is not all. We have also been working on some more advanced, I would say, machine learning algorithms to build more robust machine learning models, understanding or trying to quantify the uncertainty of the model. So it's not only predicting, for example, benign or malignant, but we try to see how confident this model is in predicting those classes, basically. We also were trying to see if we could also do some sort of out of distribution detection. So basically, if the data comes from different demography or different distribution, we could tell the model, well, this data comes from another demography that I haven't seen it before. So you probably need to be a bit careful when you indeed use the prediction of my model, right? So this is where we talk about out of distribution detection. We tried also to build more models which are fair with respect to gender, age, race, and so on. But all in all, this is what I like the experience I accumulated over a couple of years. I found out, well, we need to basically distill the knowledge that coming from different institutes over the world, right? And this is where we came to the federated learning. We just published it like a few years ago. We had also this special issue that along with a couple of my colleagues, we edited basically at the transaction medical imaging, mainly focusing on federated learning. We had also this publication where we benchmark the federated learning approach on a couple of medical databases, pave the way for our young researchers to basically make it easy for them to benchmark their models. Now, let me move on to the introduction of federated learning. I don't want to go through the math, but it's just in a nutshell, basically, you would like to train a model. Imagine this is regression or classification, simple classification model, just to tell, given the data, let it be imaging or some electronic records, we want to tell if this is benign or malignant. Now we have a constraint though. So we have data distributed in institutes basically, but we are not allowed to share the data from one institute to another due to privacy concerns. So what we do basically, we try to initiate a model parameter, for example, cloud or one of the institute. Then we share these model parameter to all the institutes. Then we train it on their own data. This is local. Then we share the updated model parameter back to the cloud, basically. Then we do simple weighted average according to the number of data points in every single institute. And we average that parameters, and then we send it back again to the model. We train it on their data, send it back, and just do the averaging. And we repeat this process until some sort of convergence, until we are happy with the performance of the model that we do have, right? So this is just in a nutshell, like a very simple words, basically. Now, it would be great if you could join me this quiz, basically, and answer this question. Why you think the federated learning considered a game changer in the medical research? Would love to have some participants. Yeah, we have 2 answers, probably. A few more. Indeed, we might have a winner. So, I mean, uh, well, there must be some answers which are quite correct, but would be great. I mean, there must be like the top accurate one, probably. Yeah, I mean, I can tell there are a few things that they are really well correct. But let's just look at the top answer. Well, let's just move on, just for the interest of time. All right. So, well, sorry. So basically, yes. So there's 86% of the people, at least the participants, says this is allows collaboration without sharing data. This is indeed what I just said. Perfect. So we might have a winner here. Kauthar, amazing. So she did it in only 25 seconds. Perfect, Kauthar. Thank you so much. Normally, I do have some presents, like if I'm in, like if I have it in person, but just promise, give you some presents at some point offline. So yeah. All right. So let me just give you more why we really need it. There has been a lot of work, like published a few years ago, showing like, well, there is a increase in the model capacity. There is also, improvement in terms of GPU power, computational power. However, the data set size just still steady there, like 1 million data points, which is the ImageNet. So those authors basically trying to see if we just increase the amount of data, can we basically improve the performance? And this is what they were doing. And you could see basically how the average precision just improved, well, logarithmically with increasing data. So this is basically the take-home message from this work. This access to larger scale database is the key to improve the performance. However, well, you probably have heard about this long tail database, right? That we do have probably a very few classes like benign malignant for certain diseases, which we have a huge amount of data. But there are so many diseases that we just overlook, and probably we don't have much data on those diseases, right? And probably there's also some open classes that we haven't seen. Just think about, for example, COVID, right? And this is indeed what we have seen in a couple of databases like open publicly repository databases. Take an example of cardiovascular diseases, where you do see, for example, the majority of the data comes from, for example, the US and probably the Europe, where we have only very few and limited data from basically like the Middle East, South Asia, and the global South, basically, right? And this is basically where also you could see how AI research is basically also grouped into more the global north and a few probably countries in the global south, right? So in short, we would love, I mean, it's access to large scale database is the key to improve the performance. However, it's not straightforward, particularly when we know there's also some privacy concerns. You must be aware of this work that, well, then they have basically the photo recognition or face recognition database along with the CT data, they were able to reconstruct basically the faces, right? And this is where a lot of recommendations came recently, just telling, well, we need to have those privacy preserved machine learning and namely federated learning models that could just preserve the privacy of the patients. That brings me to probably one of the very few last questions. So what challenge that you foresee in federated learning? You posted here also a couple of challenges. Probably the majority are correct, but from your perspective, what would be the most, well, challenge one? Privacy issues, right? This is pretty cool. Like we can see the live, basically, okay. A few more participants. Pretty cool. Few more. Interesting. So we see like the data heterogeneity, privacy issues are quite similar with 60%. I would probably also move on just for the interest of time. What I can tell from previous also cohorts, The majority basically were voting for standardization. And this is also quite similar to the data heterogeneity. So you see here also like this is the number of samples or the sample size. And there's a lot of also basically cohorts just say we're telling the data heterogeneity in terms of population, class imbalance, bias, domain shift. This is like one of the challenges that we do see here. And this is quite similar to what also you reported. Privacy issues, of course, this is one of the challenges, right? But when it comes to the medical data, etc., to the nature of the medical data, we do have also tons of also problems that we need to solve from a technical perspective. And this is indeed true. If you see also a couple of publications, we can see if we do have heterogeneous data, and the heterogeneity comes from a couple of sources that we're going to talk about it, would indeed drastically drop the performance from like, for example, 80% to 40% due to this data heterogeneity. I don't want to really go like into the details of this. There's a lot of solutions that mitigate this challenge. Probably you can also go through these solutions at some point later. I would probably just, once again, for the interest of time, I would probably just move on to the solution that we propose for the brain imaging. Once again, the data heterogeneity comes from the intra and interscanner variability, demography, multimodal data, noise in both measurements and annotation. So let's just quickly go through this work that we published in Nature Machine Intelligence. So basically the idea here, can we detect brain lesion in brain MR data using only healthy data? So without annotation, without asking our physicians to annotate or let us know where is basically the pathology, right? And we thought maybe we could do it, collect the data from a couple of institutes, and we could test it also of multiple institutes with this heterogeneous data, right? And this is based on also previous successful series of work where we're able to detect those lesions basically in brain MR. So the basic concept is pretty simple. You train the model on healthy brain data, and then whenever you test it, you give the model this data with anomaly with, for example, MS lesions like multiple sclerosis. The model basically tried to reconstruct the data. However, since the model hasn't seen those pathology during the training, the model would just generate pseudo-healthy version of the input data. And whenever you simply subtract the data from the pseudo-healthy, you would get basically only the pathology. This is the difference that we see it here. And this has been seen in a couple of you could see it here this is like the pathologies that annotated by the radiologist. And this is the one that we get it with a simple subtraction arithmetic operation, right? And we show that also numbers, how these models are indeed even generalizable to unseen pathologies. And now think about it, we would get some healthy data from a couple of institutes and train the model to do basically anomaly detection or pathology detection on unseen data, right? One of the problems that we have, notice that the data comes from different scanners might differ. So this is like an example came from our colleagues from TU Munich. They scan the same patient on multiple dates, right? By multiple scanners, GE, Philips, Siemens. What you see on the right-hand side, basically, the volume of those MS lesions. And you can see, for example, the patient if it comes on whatever, October 14th, and then scanned by Siemens would just lead to 5 milliliter. But if comes the next day or even the same day, but scanned by GE, that would be just doubled to probably 9 milliliter, right? So this interscanner variability, right? This interscanner variability is quite serious issue. And we need to consider it basically when we train the algorithm on this data coming from different population, different demography, different scanners, and so on, right? So this is where we design our algorithm to basically try to model or the representation of the data to have something for the shape, the brain shape, basically, which is common different institutes. We know how the shape of the brain, across different population, etc. and model the appearance, how the image look like. Probably it's a bit brighter, it's a bit darker here and so, here and there. I don't want to go through the details, but I'm pretty interested, like, well, willing to address whatever questions that comes afterwards. And we try to, well, train it on 1,500 scans, well, validate it on YIP and like 500 scans. And this is where you could see basically how those data points that they are close, that they are indeed similar in terms of shape, right? You see it, they are close in terms of shape. They are coming from different databases. They are close to each other's when we talk about the shape representation. However, their appearance representation, where we keep it local, basically, it's, well, has been distributed nicely, right? And that indeed help us in detecting those lesions and segmenting them properly. And this is where you see like how our algorithms that you see it here will improves, I mean, in terms of segmentation upon the baseline and also the state of the art that we see it in federated learning. Yet there are some also limitations. We have seen that the models basically failed for those small lesions, particularly for multiple sclerosis. You can see here, most of the models were not able to detect those MS lesions, while our model probably does in some, well, some cases, but not, of course, the majority. You can see, well, most of the models just fail. We tried also to see if there is some sort of bias in terms of, with respect to age, gender. We have seen, well, the distribution was quite nicely. We see also like the models were doing great in brain tumors, but not really for multiple sclerosis. This is something that we just mentioned in the slide before. Just to wrap up, I mean, we have indeed did a lot of works also in like skin lesions, MS for liver segmentation, CT and MR across multiple institutes. So you could also go through the papers if interested. Just to probably sum up and probably go back to the book that we just mentioned it by Jim Servitsky. We probably just mentioned there are a few conditions that he set for this collective intelligence, right? I would just probably quickly list them because we are running out of time. He mentioned diversity. So you could think, so he of course mentioned those conditions on people, crowd, but just draw the analogy and talk about institutes or healthcare institutes, medical institutes. So we need this diversity, independence. This is quite important. And I think what I found it really quite interesting is this decentralization, or what he call it basically the stacked knowledge. Of course, he will probably refer to the environment, culture, maybe dialect, language, and so on. But also we have this high level meta knowledge that we keep it, well, we have high level meta knowledge about the shape, but we keep also the stacked knowledge, this local knowledge when we talk about the appearance. So we keep it locally for every single client. And I think what is quite important is the coordination and aggregation among those institutes. This is quite also important. I think there is still a lot to do, particularly when we bring institutes from like global south, there's in global north about incentives. This is quite important when we bring these things in all like institutes all together in a federated learning. But this is something that I would love also to discuss with you, probably, guys. I think this is the end of my talk. I'm happy also to address any questions. Probably we go for the breakout room, probably, Rebecca, then we go for the Q&A. I think I do have a slide for that. Yeah, maybe we just go for that at some point later.